Welcome to SEMA Sessions, a podcast from SEMA Surgical Intelligence. I'm Faris Antaki, an ophthalmologist specializing in retina surgery. In this series, I sit down with surgeons from around the globe to talk about surgical expertise and how it's really built. We talk about the parts of surgery that are hardest to teach, how surgical judgment develops, what experienced surgeons see when they watch a fellow operate, what habits matter more than people realize, and what lessons only become clear after years in the operating room. For our inaugural episode, I'm joined by Dr. Sunil Srivastava, chairman of the Cleveland Clinic Cole Eye Institute. Sunil is an exceptional clinician, researcher, educator with major contributions in retinal imaging as well as uveitis. His day-to-day work centers on caring for patients with complex retinal and uveitis conditions, both in clinic and in the operating room. Until recently, he served as the program director of the Medical and Surgical Retina Fellowships at Cole Eye, and he has trained more than 70 fellows and more than 100 residents. In 2025, he received the prestigious American Society of Retina Specialists Crystal Apple Award, which is an award given to an educator who has gone to great lengths to advance education and professional development of young vitreoretinal specialists. Sunil, thank you for being here.
Thanks, Faris. It's going to be a fun time.
Awesome. So let's start with the first question I like to ask. And this is really the idea behind this podcast, deliberate surgical learning. Mm-hmm. When you think back to your early years and you compare yourself to now, what has changed the most in the ways you think, the ways you prepare, or even just move during surgery?
Yeah, I think I feel for my surgical mentors. I have a feeling I was annoying. I have a feeling I wasn't, I didn't listen. I think I did, but I would have to probably ask them. How I think I've changed is so much more happens before surgery now for me. Thinking about the surgical procedure, looking at the images, almost mentally doing the whole surgery in my head before we even start anything, looking at the anatomy and trying to decide where the pitfalls may be. And I think mentally comparing it to previous surgeries I've done, especially because I do some amount of uveitis and some complex retinal detachment work. Some of the cases I think are a little more complicated and take a little more time to think through. So I think I know I'm thinking more beforehand. And during surgery, I'm looking for clues about what the next step is. For many fellows, we are regimented of we're doing this and then this and then this. And you and I have operated together, and all of a sudden I'll say, "Hey, why don't you go do this?" And I think that's hard sometimes because you don't see what I see. And I try to get you to see what I see. So, for me, I think it's much more visualizing the process and recalling previous cases. And that comes just with time.
So that's interesting. You mentioned time. At what point do you feel like, it just clicks and you know what the next steps are, you know how to move? Does that happen as a trainee or when you're an attending?
I think it happens at a trainee level. I think you become more comfortable, but I'm still not comfortable. And you and I have talked about this, is that I think the beauty of our field is you become comfortable with being uncomfortable.
Yes.
It's a logo we have at Cole. You have to figure that part out. I still get nervous. My heart races a little bit before the complex ones. I think a lot about the ones, monocular patients. So I just had one within the past couple of weeks of somebody whose other eye didn't go so great. And I wanted this eye to go perfect. And I spent so much time thinking about it, still accomplishing everything we wanted to do, but I was thinking about it a lot more. So I think if you're a surgeon and a dedicated surgeon and physician for that matter, I think it's outside the operating room too. These are things you continue to think about and worry about because these are human beings in front of you. These are people. These are people you've developed relationships, and they put their trust in you.
Absolutely. What do you think, makes a difference if we can break it down into specific things? So is it volume? So doing more surgery helps?
Some of the greatest surgeons you ever trained with probably didn't do as many cases as you did in fellowship. So I don't think it's volume per se. I know that's hard for people to see. When you're looking for a fellowship, we all get seduced, if you will, by the number of cases a place says that we offer. And Cleveland's a great example. When I came in 2010, I think our fellows did 300 to 400 cases, and now they do, 750, 800 cases. Do I think the surgeons are better now than they were, 15, 16 years ago? I think they're different. I think the thinking process is a very dedicated process. So when there are fewer cases, what we used to do was review many more steps or talk about them a lot more. I think it's being just very intentional of what each step means. I think what volume gives you is an opportunity to do this on your own, if you will, and mentally be prepared for it. So for fellows who work with me very much in their second year, or when I think they are starting to get it, I don't talk as much. I just see if they are doing the steps, or I'll ask, "What are you doing next? Give me an idea what's next. Why did you do that? Why are you picking that instrument?" So a lot more questions, which are annoying, as you know. Operating with me can be annoying, but very clearly for the intended purpose of helping you figure that out. I like to say, if you can dictate the case before you do it, you're in the right place. You're doing well. But the comfort level, I think, comes from being really self-critical, and you guys have an advantage now that we didn't. You can easily review your cases. You can easily look at them because they're all digital, and you can download them the same day. And not that you have to sit while eating dinner looking at cases, but you can take the time to say, "Boy, I really had a hard time with that," or "I really did that nicely. What did I do differently? Because I didn't do it like that a couple of weeks ago." And I think that's the beauty now. I think you can actually get there a little bit faster because you have the ability to review things. And I think if you're intentional about it, and even looking at, your trocar placement, or like opening and closing, or how you throw a suture, and critically look at yourself, you can get there faster. Because you're going to see it. You're going to understand why your hand is in the wrong position, and it will click with you, because it did with me, and I think it does with others. Oh, I should be holding it this way, or why don't I do that left-handed? Why was I doing that right-handed? And you just start to see it. And, fellows who do that, who spend the time, I think get there faster.
So is it fair to say that if you, as a young surgeon, have the habit of, self-reflection, being a little bit obsessive about, how you're doing things, does that make you better?
I think it allows you an opportunity to be better, for sure. Just like it's in clinic, for that matter, right? If you review cases of how you've treated patients, or reviewed imaging findings and looked at them afterwards, that's going to make you better. Seeing your post-ops and seeing what they look like, and then going back and looking at the surgery. That we don't do that too often, right? We see the post-op 3-month, they look great. You don't go back and look at the surgery, but it's the fellows who do that. And I'll say sometimes, "Hey, go back and look at that surgery. Remember how complicated this was? Look at how they look now." That's amazing. And I think you are able to pick things. So yes, being obsessive helps. I think being humble helps. I think figuring out that you need to get better is okay. And avoiding the noise. It's so hard because all the fellows you're very interconnected. The ones who are at other programs, or you watch people do things online, you at these conferences, and I'll hear you guys say, "Wow, that's pretty cool," or "That's amazing. I don't know if I could do it." And I'm like, "Yeah, you can. Of course you can." Just staying in your own head and space, you're going to progress at your own space, and you progress so much more afterwards. I mean, we do the highest volume of surgery in fellowship, in the sense that more per week than you probably will in practice, but you're going to do more in practice, right, over time. So that gives you an opportunity to do it on your own, and that's just the next phase of learning for you. So I think very much reflection, very much, I don't want to say obsession because that's a little negative, but reflection and humility make a big difference.
You touched on an interesting point. So some trainees, let's say medical students who are not sure whether they can do a surgical specialty,
Yeah.
sometimes they're worried, are my hands going to be good? Am I going to have a tremor?
Mhm.
Can I do this? Can I, work long hours and still be, safe and do the right job?
Yeah.
Do you think some people can do surgery and some others can't, or it's something you can learn?
Yeah, that's a really good question, Ferris. But you think about it, we at our level, we only see people who have self-segregated, right? So I don't know if people who think they can't do surgery choose ophthalmology.
Mm-hmm.
Maybe they do, and maybe they just don't say it. I have operated with people with tremors, and who have done fine. And one in particular I'm thinking of, I thought was an excellent surgeon, and he trained him in my early days, and he was phenomenal. He was great. So yeah, maybe there was a tremor, but when you got down to the macula, steady as you could ask. So I do think some of this can be learned. I do think some of it can be trained. I do think there's an inherent skill set that we all have to have. But, do you I think you pick this because you feel like you can. Mm-hmm. So I think we're all it's not like there's like, these are like basketball players, right? Or golf, or athletes who are the exceptional 0.001%. We have probably a set of people who maybe their hands aren't necessarily as smooth as others, but are able to do an excellent job, because it tells you that I think our technology is pretty good. That's one. I think the other thing is that sometimes it's pre-op and post-op care that matters. That's number two. Surgical judgment makes a huge difference. And if you think about our surgery, sometimes doing too much is the worst thing you can do. Sometimes doing less is actually better.
Yes.
And I don't know, you have to do some of these complicated moves that we sometimes say we do. There are people out there who like to peel ILM on numerous different things that I don't tend to do. And I think my outcomes are pretty good. But, it's pretty cool when you can do it, when it's a detached retina and things like that. So, I think there are, I think surgeons who maybe aren't as confident figure out a way, or not confident, surgeons who are comfortable with doing certain maneuvers figure out a way to do a great job because they excel at other things. They're not great with their non-dominant hand, but they're phenomenal with their dominant hand. So when things are in the wrong place with their dominant hand, they just figure out a way to do it. I think there are things that people compensate for over time. I think surgical judgment is the big thing that I think is the hardest thing to teach. When to operate, why am I doing it, and the decision to do some maybe more complicated maneuvers. I think that's where people get into trouble sometimes, and that's where I think talking about it makes a huge difference, or working with somebody on the outside. I think those are things you can figure out. You want to have a forum to do so.
And so you touched on interesting points about, yes, people probably self-segregate, and if they they feel like they may not have the personality or the ability to do some specialties, they won't do them. But a lot of the surgical expertise is really hard to describe because it's really small details. So in ophthalmology, in our field, in retina surgery, it's like visualization, tissue handling, ergonomics, anticipating the next move. So, when you watch a trainee operate, let's say for the first time, they come into your OR, this is the first time, in the first 30 seconds, you probably form some sort of judgment on how they are.
Yeah, I think so.
What is that feeling? What are you looking at?
It's probably, there's so much bias in it. It's probably, were they nice to me before the operating room? And, did they do all the steps before, get the consent done, put the orders in? I think we're making judgments sometimes based on non-surgical things, but that's it. Hey, I'll tell you something Tom Alberg Sr. said to me. So one of the original people in our retina surgery, for those who don't know historically, please look him up. Tom Alberg Sr. was the chair at Emory for years, but worked with Robert Mockemer and was Mockemer's first fellow. So one of the kings in our field, if you will. And I remember Tom telling me that the best retina surgeons tend to be excellent anterior segment surgeons. He could tell when talking to the cataract colleagues who were training them how good of a anterior segment surgeon they were. So if they were going to go into retina surgery, they were excellent anterior segment surgeons. And so that tells me that Tom was looking for something, and he did it for a long, long time. Tom was looking for something where people were trainable, so would listen, were willing to make adjustments. I think those are two things. Third is that they could do things bimanually, like they could use both hands. We use both hands and both feet. And I think that was the subtle context that Tom was getting to. Throwing a suture makes a huge difference. Those were the days when we threw more sutures, making a wound carefully, being able to meticulously identify tissue planes, as you said. We're doing it through a microscope. So I don't know if it matters necessarily in the retina or on the surface of the cornea or the sclera when you're making a scleral tunnel. So think about making a scleral tunnel wound over and over again. You probably, in doing it correctly, 50% depth, making sure you were doing it at the correct plane. That took some skill. And that's why I think Tom was very correct. Now, do I still say the same thing now? Yeah, I think so. I mean, maybe we don't do the exact same things now in cataract surgery, but that same concept of someone who's trainable as an anterior segment surgeon will definitely plays a role in posterior segment. So to your point of how do I know in the first few minutes, if you will, the first case, did they listen? Are they able to take somewhat of the direction when they make a mistake? Because we all do. How do they handle it? That's the hardest thing. This is a mind game. What was it like the first time you did? I would flip it around and say, like, I'll talk about myself and we can talk about you. But I remember the first case and not doing something correctly. You kind of go home and say, I'll never be good at this. I should have done something non-surgical. And then you get yourself back up and you're like, no, wait a second. I think I can do this. I can. Okay. What did I mess up on? What can I work on? I'm going to go to the wet lab and work on this. Or I didn't read the note properly. Okay. I need to readjust how I read the note. I didn't understand the surgical plan. That's my fault. Let me read a little bit more. So some of these things you can work on, right? I think the hardest things, we don't necessarily give the feedback that everybody needs. Sometimes you'll just hear, how did I do? You really want like a complete sketch of everything. You want the analysis that they do on television for all the sports, right? Someone who meticulously breaks you down of all the things you did right and wrong. And what do you get? Nice job. Or, yeah, you could have done better. And you're like, wait a second, tell me more. What did I do right? What did I do wrong? That's why I think it's important to look at videos and such. And then, I think the better educators have that conversation of like, hey, look at your move here. You didn't do this great. But we're saying it to you at the time you're operating and you're going to forget because you're sweating and you're nervous. So you have to kind of make a mental note. And sometimes I'll say that to fellows of, hey, go back and look how you peeled the initial part. You didn't do that right. And I think you could do that a little bit better.
So that, you touched on an interesting point. Giving feedback can be hard. Giving good feedback may be much easier than giving negative feedback.
No, yeah, it's easy to say, great job, right?
Great job. But so how do you do that? And sometimes you can get along with trainees, and because we're all different human beings, and sometimes you may not get along with a personality. So how can you continue to teach and, devote yourself to improving that trainee that you may not get along with?
Yeah, this is I talk about. This is a slide I have when people ask me how to become a great educator and or how to become a really good educator, and I say, ask yourself right now, how do you treat the people, or how do you educate the ones that you don't like or you don't have a rapport with? And they deserve as much attention as the ones you like to hang out with. And when you're a fellow, you're so close to the residents, and you're educating them, and you develop, probably, you've met residents you like, and you've met residents you haven't liked, right? And it's so much easier to say, oh, I'm going to go help this resident out in the wet lab that I like. Well, why aren't you helping the one that you didn't like, right? So for educators, we have to put that to the side. It's hard to do because we're human. So, the feedback part, you've heard me. Sometimes I'll just like growl, for lack of a better word, like, come on, what are you doing? Or especially suturing. That's my biggest pet peeve, as you know. And that's not useful in the moment. And I realize that. And as an educator, and I'm using educator in quotes, but as a person who's, training someone, I recognize that and things that I'm working on, verbalizing it. Sometimes it's hard for us. Sometimes it is very challenging to give it because there's so many things going on at the moment, depending on how much of the case you're getting to do and such. We're trying to manage these things. So I think over time, as I became better at this, my feedback was very direct, or is very direct, very targeted in the sense of, I want you to work on this, and maybe not. I don't necessarily focus on the good unless I think the person needs it, right? If they've had a rough patch of like, hey, you did that really well. I know things haven't been going great, but you definitely could do this. Now tell me what you did differently. And most of the time I put it on you, and you're like, I don't know what I did differently. It's like, okay, well, maybe you're finally figuring it out, and you need to reflect on that. So yeah, we can all do a better job with this. We're all trying to, as you know, at Cole, we have now tried to develop this like standardized sheet where we give people feedback. And again, that's great. I think it's wonderful. It's yet another form to fill out, right? And are we going to be good at it? But can I flip it?
Sure.
What do you find is useful? What have you found as useful feedback as a fellow? I mean, you're much closer to this than I am. So am I allowed to like ask the podcaster questions?
I guess you can. This is the first episode, so
we can do whatever. We should have you should have a section. Ask me anything. So here, yeah. So what kind of feedback has worked for you?
I think so. When things are going well and you feel like you're doing the right things, I think positive feedback can be useful because it can reinforce that the steps you've done, okay, they're good, and that's where you're expected to be. So positive feedback helps when you're doing well, and as you mentioned, when you're having a rough patch. So if as a trainee you feel like you didn't do as well, or you got some negative feedback before, or you just some weeks and days are harder than others, so that can lift you up. But the most important and useful feedback is critical feedback, and I think delivery is very important. So I think you do a good job at delivering critical feedback in a nice way. I think delivery is very, very important. So as a fellow, I don't think any trainee or fellow minds, critical or negative feedback, as long as, the delivery is smooth and nice.
I've asked fellows, because I've given this lecture at a couple of different places on, feedback. And somebody said, and I don't remember who, so I apologize if you're listening, and I hope you're listening because I'm sure this will be great. But they said, remember, we're working with adults. These are people who have made the decision to spend 2 years with you and do a lot of things for you. And, so treat them like adults, don't treat them like kids. It is hard for us sometimes, I say, as an attendings, not to look at somebody who's sitting with us and we're giving advice. And if you have children, not to in some way have this paternalistic, view and opinion. I will say, I say this to my kids all the time, that they have made me a better at training fellows and residents, because they are very direct with me. Like, that didn't work, Dad. Like, don't say that to me. And so, and those are teenagers, if you will, and young ones now. They're, and I do think that training fellows and residents made me a better parent, because I do see like similarities in some of this. So I think you're absolutely right. I think for me, as time has gone on, figuring out ways to give directed feedback, not only in the operating room, but I think in clinic, it's really important, because, in retina at least, and in ophthalmology, you spend so much more time in clinic, and the volume is so high, the amount of time we get. So how do we develop those, thinking skills to let us go through this? So as much as it's great to hear that feedback in the OR because it's very directed, I do think sometimes we also have to direct it in clinic of, I'll just pull you aside. Hey, you said this. I don't think this is correct. I think you should have done this. And I do it in front of everybody. I want people to hear the good. I want not the bad, but to see the challenges, because we learn. And that's actually a really good point. As I think about this, as you maybe think about how do you deliver feedback maybe to people who you don't have that connection with. If you see that those people see that you're giving the feedback the exact same way to everybody, right? I am hard on Ferris. I'm hard on, his co-fellows. in the exact same way, and I'm calling them out in the exact same way, or I'm praising them in the exact same way. Then I think it's a little bit easier for someone who maybe doesn't feel that connection to say, okay, I'm getting the feedback that is warranted. But I am very much I'm going to tell you directly what I think is going on. I'm at least going to try. And sometimes it's hard. It's not easy to hear that because, just what are you used to? And some people don't respond to it.
Absolutely. And I think most trainees appreciate direct feedback because they realize that, this educator, this teacher is, devoting time and effort, and they're putting themselves in a slightly uncomfortable position to tell you how things are.
Yeah.
And I think most people appreciate it.
Yeah.
And they much rather have that than be in a place where, you feel like you're doing well, but you're just cruising and 2 years pass by and you're like, oh, am I ready?
Yeah.
So most people appreciate that.
I remember I had a fellow at the end of their training, I think they were like a couple weeks away, and we were in the operating room and this fellow just started running through scenarios with me, okay, what if this happened? What should I do? And I kind of looked, I was like, well, what are we talking about? Like, you're talking about the most rarest things. I thought they were quizzing me if I've ever seen it, like a retro, like a suprachoroidal hemorrhage that happens, or, some like a patient's bucking during general, and like, what do you do? And then I realized, no, this was actually them they were not comfortable, right, with this. They didn't hear these things or see these things. So they were very worried about like the next phase because they realized they were coming, to the next phase of their, they're going to be out on their own. So it highlighted for me that it really is incumbent on the trainee to do some of the stuff. I can prepare you for so much, but it's not my job, if you will, to come up with every single scenario and to show you every single surgery. I'm doing surgeries now that I never did in fellowship, right? And you and I have talked about that. I was a 20 gauge guy, and we did, contact lens. That was the Duke way, and now we're 25. I'm a 25 gauge guy, and I'm using intraoperative OCT on most of my cases. We didn't do those things, and so you have to be prepared for the process. And bad things have happened to me in the OR in the as an attending that never happened as a fellow, but the thinking process started as a fellow, at least.
So I'm going to talk about complications because I think they happen to every surgeon.
Yeah.
And so every surgeon will have difficult cases, complications, moments they kind of replay afterwards. I want to ask how those moments have shaped you, and we've spoke about them briefly, but I really want to focus on, I want to take the example of athletes. I want to take the example of Novak Djokovic, who is probably the greatest of all time tennis player.
Sure.
A lot of people say what makes him unique is that he can move on. He can be down 5-1 in a final set and then come back and then win the championship.
Yeah.
And so despite losing the point just 2 minutes before.
Yeah.
So how do you go from I had a complication, I need to learn from it, but I need to move on very quickly because I'm operating a next patient right after?
Yeah. Yeah, I don't know if there's a right answer. The athlete correlation, or the athlete analogy, I think works sometimes, and this one I don't know if it does, because we're dealing with a human being on a table, and so when you have a complication, it has a negative impact on somebody that has trusted you to do something for them. So I do think that there's an immediate, how do I connect with this human who I was supposed to help, and I think I've harmed, and that is hard. That is really hard for us, and I'm really hard on myself. I'm hard on you guys, but I'm hard on myself, and thankfully I have a pretty good support system where people around me, whether it's my wife, whether it's my nurse Kim, who helps me with this, and it's my trainees too, where I openly talk about them and say, yeah, I didn't do this right, or this didn't go well. So in the immediate period, just thinking about cases where we've had this recently, it is very much, okay, I'm going to go talk to the patient in the post-op area. I'm going to talk to their family. I need an extra X number of minutes before we do the next case. And some of that is verbalizing that those problems and still establishing that relationship with that patient who's put this trust in you, because I do think honesty is important. And at some level, it gives them an opportunity to start processing it so that you can answer the next set of questions. I do think it takes you a few minutes, right, to kind of recover, at least in the short term, of, okay, what did I do, and is that going to happen next? And sometimes it's, a very particular thing that occurred that are rare events, right? Or I had a day where the machine just seemed not to work for me, and so that I don't want to say I blamed the machine, but the machine had an issue, and it was very much okay. Is this a safety issue? Do we need to take this machine offline and consider something else? So I do think a little bit of reflection is warranted of what exactly happened there. Suprachoroidal hemorrhage happening during, say, the case, looking at the blood pressure. Mm-hmm. The blood pressure was really high. The pressure was low in the eye. It was a high myope. A deep pass during a scleral buckle that occurred, and made all these things happen. Okay, I'm doing, the next case is, vitreous hemorrhage. I don't say fluorectomy, but vitreous hemorrhage, completely different. Let's make sure we're doing these steps right, and make sure we're not doing the same thing. And then I think I think most of us are able to get to the next case because we were ready to do so. I think it's going home at night. Mm-hmm. And then, because I reflect on this, and I think you do too, all of us do, we just kind of, what's the first thing your better half, asks you, how's your day? And sometimes I'm ready to share, and sometimes I'm not. Sometimes I'm like, yeah, it was fine. A little rough patch there. My wife Rachel is pretty good at tuning in. Like, that doesn't sound right. And we'll be middle of kid stuff, and I'm going to focus on them, and then time to reflect later on. I do find that sometimes looking at the case helps me, run through it, or I'll say to the fellow, just put that together, send it to me so I can look at it, so we can learn together, or let's reflect on this together tomorrow, and let's walk through these steps and what did we do right. And I do think the only credit I give myself sometimes is I think I can make a good decision. Mm-hmm. So when a complication occurs, I don't really get hung up on the complication. I get hung up on the decision I make right after that.
To solve it,
right? Did I make it better, or did I make it worse? Mm-hmm. And I will say, in the moment, unless it's like a critical thing that you need to, you need to jack up the pressure really high, you have to make a decision very quickly. Sometimes it's okay to just stop. And I don't know if you and I have done this, Ferris, but I know I've done this with fellows where I'm like, we're just going to stop right now, and I need 30 seconds to think. And I'll just sit there and think and walk it through. And, I talk out loud often, but I'll talk it out loud. And if the patient's awake, I'll just say to them, hey, I'm thinking something through, so you're going to just hear me just talk things out. And sometimes anesthesia figures it out and gives them a little more sedation so that they're calm during it. So I do think that the decision-making process immediately afterwards is really important. And sometimes you don't know what the right thing to do is. I've done this in the middle of a case. Something has occurred. I stop. I walk over to the phone. I pick up the phone and I call somebody. Somebody who's wise, somebody who's been through this. My partners, I know I've done this. When I first got to Cole, I would call John Sears, and John is, for those who know, I'm a phenomenal surgeon, one of my partners here, and I've known John forever. And John always picks the phone. Yeah, here's what I would do. And I get that phone call now. Even sitting in my role, the nice thing is I sit in a chair office now, so I can answer phone calls. But I'll get that call from people in the operating room saying, "Hey, something is happening right now. What would you do?" And actually what I do is well, tell me, what would you do? Let me walk through with you. And I think that's the right idea. I think you're thinking the right way. Consider this too. This is what I've done. So I do think all those things are appropriate. You don't have to know all the answers. You're allowed to phone a friend. You're allowed to stop.
I think you mentioned an important point is, obviously you want to talk to the patient, explain what happened. That could, of course, happen after the surgery.
Yeah.
One interesting and very useful feedback I've had when I was a tip I've had when I was a resident is, if you have a complication and disclose to the patient that this complication happened, and they feel like you're caring for them, you're honest with them, oftentimes they're going to be the ones making you feel better.
Yeah.
They're going to be like, it's okay. Things happen, and we're, those are meant to happen.
Oh, I could tell you. So I have this story I tell, and it tears me up every time I tell, but I'll tell the story. So I have a patient long ago, who it's a bad uveitic patient, essentially lost one eye to the uveitis, and I was taking care of him, and he had a bad flare. We were adjusting his immune suppression, and he needed something done for him. So I gave him a local steroid injection, so a periocular steroid injection, and I gave it to him, and he had immediate loss of vision. So I think I got it in his, in his vortex vein, and it included. He lost a significant amount of vision because of it. You could see the triamcinolone crystals when you looked in the eye. I was in miserable pain. I still remember I can hear the scream. I thought maybe he had a retrobulbar hemorrhage. I did a canthotomy, cantholisis in the office, admitted him, all this stuff. He lost vision. We were able to get some of it back, but lost it. But this was like a 20/60 eye, and I think he ends up 2200, 2400. And this is better seeing eye. I mean, I think I almost quit Ferris that day, or I think I almost quit that week. And, again, Kim and Rachel will tell you, the amount of mental help I need. He sent me a thank you card. A thank you card. I mean, detailing all the things I had done for him. He was thanking me for helping him. He was thanking me for taking care of him. And I just would tell people all the time, I mean, this person is nicer than I think I would be. I mean, but at the same time, it does tell me the most important thing of communicating with people and having that connection. And I think, I think patients are aware they're in tough situations, and you're doing the best for them. Some of these things are human, right? I don't think I did anything wrong. I mean, clearly my technique wasn't, I think my technique was fine, but he had a rare complication. I've done thousands of these things, right? And I remember walking over to Corrine Lauder, who was my partner at the time. I said, Corrine, have you ever seen it? She's like, oh yeah, I did that 25 years ago. I wrote a paper about it. She's had the paper ready. She's like, yeah, happens. And I kept doing it for 20 years, kind of move on, right? Good to hear that from someone who's done it, but to communicate that with a patient, for the patient to kind of come back and say, thank you is, I guess, as I said, such a mind messes with my mind still today. But I think it shows the most important thing sometimes is the rapport that we build with patients. And that happens in the pre-op space. That happens, before you're in the operating room. That is, I took care of this guy for 15 years before, or 10 years before this happened. And, so that equity meant something, right? To him. So, I do think, making sure they have that connection is really important.
Well, thank you for sharing that story. I want to move on to a fast-paced section. So I'm going to ask you a couple of questions, and I'll have you answer with one sentence. Okay. We're going to start by talking about the hidden curriculum.
Okay.
So I think it's something important. We don't say things explicitly sometimes. So I'll tell you a few sentences and just try to fill the
Are you saying I'm answering too long? I like this. This is good.
We're just adding some tempo here.
I like it.
So nobody tells you that surgery is really about.
Okay, I got it. So I have to fill in the blank. Okay,
correct.
Nobody tells you. Oh wow. Oh, okay, I got you. Nobody tells you that surgery really is about. I don't see if the sentence won't make sense, but it's a mental game.
Mm-hmm.
In one sentence, surgery is so much more about the thinking than the physical part.
Perfect. The best surgeons are not the ones who
do the fastest vitrectomy. The best surgeons are the ones who are thoughtful.
The hardest thing to teach is
resiliency. I think we all think we have it. I think you described it in the story about or we were talking before about complications. Resiliency, mental resiliency in operating, I think is something that is very hard to teach.
A trainee becomes dangerous when
they think it's easy.
So hubris. I know you like to use that.
Hubris. Yeah. I mean, and we all have it, right? I've seen this 100 times. Therefore, the next one must be what I say it is, and that will get you in trouble. I've done this 100 times, so this is going to go perfectly. take shortcuts. Still, you have to do it the exact same way.
This question, okay, I want you to answer this in the perspective of perhaps how things were before. I know maybe now we're dealing with a new generation of surgeons. The mistake I see young surgeons make, and tell me from the lens of this shift, perhaps.
So the mistake I see young surgeons make.
Maybe not prepare or
no. I mean, I don't think this is. But are you saying more from a generational thing, or is just
a generational thing?
So like this generation of surgeons versus other generation of surgeons. I think the difference that now, much more is. I think the mistake that I want to say it's a mistake. I think the choices I question really are at the tail end when they're choosing jobs. I think how people go about choosing the next job or the next phase of their life is different than I would think about it. But I think some of this is because the choices are different, now than they were before.
So are people thinking more of, work-life balance, or?
I think you're always allowed to think of these things. Mm-hmm. So I never begrudge anyone to say, I want, some more, I want to do fewer days. But I think people also have to realize that comes with some sort of cost, right? I think the choices are harder for you now because there are fewer private practice jobs that are maybe as nice as they used to be, or it has as many opportunities as they used to. I think private equity has changed a couple things. Not that private equity is all bad, not all of it is, but you give up something joining a private equity group. And I do think there are some bad private equity, groups there. So I think those choices are harder. When I was going through this, I looked for not necessarily where I was going to get paid the most, because we didn't, it was really where I thought I was going to have the best mentors and opportunity. I was doing academics. That was really important to me. And I think I truly believed in my senior partners and my colleagues that they would help me figure it out. I think now there's very much nuanced on, all these factors of, I want to make X amount of dollars, which is important. Don't get me wrong. That's important, but I want to have, I want all these things like kind of set for me. And some of it, you just got to kind of work through it. You don't have it. It's not going to just be there for you waiting. And, so I do think that some of the choices I think people make now are different, not necessarily right or wrong, but just different.
Let's move on to a section I'm calling split decision.
Okay, split decision.
I'll give you two options. You have to pick one first, even if the answer is it depends.
Okay, fine.
And then you can explain the nuance after.
Okay, fine. I have to pick one, but I can say it depends. All right, very good.
Is it better to have exceptional hands or exceptional bedside manner?
Exceptional bedside manner. I think the qualities of talking to people is really important. Mm-hmm. I think that's a harder thing to train people to do. Most of the time, my patients don't know how great of a surgeon you are, and they all comment on what a nice person. I would go see that guy. And I think the delta difference between someone who has great hands and someone who has average hands, I'm not sure makes that much of a difference surgically. But the delta difference between someone who has an average bedside manner and an amazing bedside manner has a huge difference in how patients will relate to you in the long run, and actually how your staff relates to you. Mm-hmm. And I think that's the hidden thing here. Your staff responds when they see that you treat people well, and they see that patients like kind of are drawn to you. You want to reduce the amount of turnover in your staff. You want people to see that they're joining a great team. And if they see you not treating people well, they're out. They don't want anything to do with it, because unless you pay them a ton of money, right? But most people are willing to take a little less to work for somebody who's great, and they feel like, part of a great team. So
and they want to help you. I mean, if you have good bedside manner, you're good with your staff, often everyone is rooting for you and they want to do everything right so that you can do.
Yeah. Everyone, I
Mhm.
mean, of course we got into this. And look, I mean, I don't want to negate anyway surgical skills. Surgical skills are important, but I do think that it tells the difference between exceptional and pretty good. I'm not sure it's that big. And again, in the world of retina surgery, for a lot of the things that we do, I do think having exceptional hands helps in some places, but I'll tell you, having exceptional attitude, whether it's, we call it EQ, whether it's treating people well, um, we all got into this to take care of humans, I think, at some level, especially the ones who don't have MDs, right? The technicians who are there, the nurses who are there. They're not making the amount of money you are, right? They're in this because they find it interesting. Maybe it's a good job and it pays them well, but they're also motivated by this sense of serving and helping others. And you talk to most of the techs, that's what they say. I want to help other people. This is a way for me to do it. I don't have the education skill set to be a doctor, but I want to kind of be involved in helping people. They absolutely, and I see it now as the chair, I mean, they absolutely gravitate to those who they think have great bedside manner, and they don't want to work with physicians that don't.
Yeah. Okay, let's move on to maybe a more personal question, personal choice. Should a surgeon operate on a friend or family, or should they refer them to a colleague?
Yeah, I think family for sure. You should refer to a colleague. Friend, I think gets. Yeah, I think it depends. I think it's more than appropriate, to send those people over to a colleague. I think you're talking about. I'll put it like this: I have I'm on call. An urgent detachment comes in, I'm taking care of whoever it is. It's my brother. I'll probably call my, somebody and say, hey, can you operate on it? It's my neighbor. The kids play whatever together. I'll probably take care of them, because I think, it's my role and responsibility to do that. It's someone I vacation with every day, every 6 months, 3 months, I'm probably calling somebody else to take care of them. So I think just depending on the scenarios, they have a floater and they want that floater removed. I am not operating on that person for whatever reason. I'm sending them to Canada to see you.
Oh, I'm not sure I'm doing that. Okay. So you've named a few fantastic mentors and teachers you've had.
Yeah.
Can you name one surgeon and one skill you'd steal from them? So you've mentioned a bunch, but only name me one.
One surgeon and one skill I could steal from them. Yeah. Oh, one surgeon. I have to think about this. There's gonna be. I'm thinking about all my mentors are all going to yell at me. I'll take it. So I would steal. Cindy Toth. She's an innovative thinker. I mean, I'd steal that brain. That's. I mean, I trained with her as probably one of the most influential people in my life. Just to see.
Can you talk briefly on what impact she's had specifically on maybe your research or?
Well, no, it's not even that. I think the skill sets that I ask Cindy was hard on me. Cindy was really hard on me, and I'm appreciative she was hard on me. Hard in a good way. Cindy's not a yeller. Maybe she yelled a little bit, but high expectations. You had to live with it. We were doing at that time. Cindy is an innovator. For those who don't know, intraoperative CT. At that time, we were doing 360 translocation. So I mean, I did a lot of these when I was a fellow. Really technically challenging surgery, but you learned a lot about. And Cindy was always thinking of something new to do. And you would sit there as a fellow doing these cases with her, and you could just hear the brain working sometimes. And it was just great to kind of be there. So it taught me that you can learn a lot from anatomy. It taught me you can learn a lot from complicated things you're operating on, and then the impact of imaging in leveling the playing field at some level. Cindy taught me that, and intraoperative imaging in particular. And Cindy's just as dedicated educator. I mean, afterwards was someone I could call and, ask, and was helpful when I switched jobs, when I left Emory and came to Cleveland. I mean, she was someone who, I asked a bunch, and she had a lot of good things to help me with. So yeah, no, Cindy's innovative brain, I would steal.
I like it. Before we wrap up, I want to ask you just a quick rapid fire questions. Coffee before surgery, yes or no?
Now, yes. Before, when I was younger, no. Now I have a better coffee tolerance.
Uh, we touched on this, but record your surgical cases, yes or no?
Yes,
Even
absolutely.
even if you're no longer a trainee?
Uh, I think so. I still believe yes.
Should you time your surgical cases?
Only in the sense of for a specific purpose. I would put it more as, I have X number of cases to do in a day. I feel like I can do more. Well, what's limiting that? Well, what's my turnover time? What's my actual operative time? Those sort of things, and then breaking it down and where's the limitation? And we see this, again, as in a new role, as chair role, of like looking at these things, of identifying places where we can save time. Part of the reason I block and I prep is I noticed that when fellows, at least with me, fellows spent more time chit-chatting and making the time longer, that I wanted to get a sense of we're operating, we're moving, and that. So, I think timing for a specific purpose, not necessarily to say I'm getting faster or better, but more in the how's my day allocated, I think makes sense.
You're saying it's important from an time allocation point of view, but is it generally true for common pathologies that faster surgeons, well, they also tend to be more efficient in their movements, are potentially, are doing patients a service from not spending so much time in the eye, less anesthesia time?
All those things are true, or maybe they're doing easier surgeries. Maybe their decision-making process is flawed at some level. So, a fast surgery. So if I told you somebody on average took 45 minutes to do non-clearing vitreous hemorrhage with laser, and the other surgeon did it in 22 minutes. Does it help? Does it tell me that they're better? Well, maybe what it tells me is that one who takes 45 minutes is actually doing more laser, and the other one's not doing as much. Or maybe it's telling me that somebody actually shaved the periphery and took a careful look. Maybe someone was trained properly. I don't know. I mean, I think it's very hard to use time as your only assessment of that, because I just would say that if you're focused on time, you're going to take shortcuts. You're going to find places to do it. But if it's like, oh, I'm timing myself, but I actually like I'm taking a long time to close, because 25 to 30% of my trach are leaking, I'm not doing it right. Okay, that's like a skill I can improve on. I'm doing my laser's taking a long time. My settings are all messed up. I'm using a long duration. I could use a shorter duration. My peel time is longer than others, but we don't know what other people are. And this is something I know you and I are working on, but maybe it's because you're double staining and you don't need to, maybe you're spending too much time. That's the feedback that we don't get right now as surgeons. We don't know what other people are doing, what the average is. And we have no ways to assess our outcomes, because we all believe we're great surgeons. Have you ever met a surgeon who said, I'm not really good at this?
No, that's very interesting.
I mean, I've never met someone who says, I suck at retina surgery, I suck at, cataract surgery. No one says that. I do think that there are some people who are more meticulous or self-described meticulous, and there are others who are more efficient. You'll notice those are the words people use. I'm really efficient in the operating room. I'm very meticulous in the I don't know what that means. I don't know what their euphemisms for I'm really fast or I'm really slow.
And, you touched on this. We're working together on ways of, determining what proficiency is. What is a good surgeon?
Yeah.
Perhaps it is, someone who can achieve the goals of the surgery in a way that they've been economical in their movements.
Yeah, and that could be it. But more importantly, getting feedback from it. Because as we touched on, it's great to do your videos, but if you don't know what to do with the information, it's hard to know. So if we had a way of assessing that, in a objective way, and then you could say, on average, it is taking me this long to get into the eye and this long to get out of the eye. That's something I can work on. On average, it's taking me this long to do a shave. Those are things that I think that people can work on, right? Not necessarily, or even it's taking me 20 minutes to actually physically do the peel, and the average is 6. So I'm 3 standard deviations above. So I'm either the most meticulous person or, I mean, and so now you can self-judge that. And I think those are things that you can work on. It's all about giving people feedback.
One last fun question. Music in the OR, yes or no?
Absolutely. So it's the best thing you can do.
Awesome.
Yeah.
I like to end with, the same idea that I'm hoping to ask surgeons in the future as they come on the podcast. And this is really for new trainees, first-year fellows, residents listening. If they could improve one thing, so, they just listen to this podcast, they need to take home one thing that they should start doing daily, that will compound over the rest of their career. What should it be? One thing.
One thing, suturing. I would say that. I would say training is very much associated. What you put into it is what you get out of it. So if you put more into it, whether it's reading, practicing, you're going to get more out of it. So that's what I would say. I'd say that I would put one extra thing a day that is focused on improving yourself, whether that is suturing, whether that's reading, whether that's listening to your podcasts, or whether it's taking a mental day because you realize it's too much. I don't know if there's one exact thing, but I do think that you have to know yourself, and each person is so different. Some people need more one versus the other. So I'd say that putting something into your training beyond the 8 to 5 or 8 to 7, whatever it may be.
Awesome.
Yeah.
Well, Sunil, thank you so much for taking the time to be on the podcast, and thank you for coming to Montreal to do this with us.
Oh, thanks for having me. What a great time. This is a lot of fun, and good luck with this.
Thank you. And thanks everyone for watching. This has been CIMA Sessions, a podcast from CIMA Surgical Intelligence.